All right. Good afternoon, everybody. Proud to be opening this meeting for you guys. Thank you for that introduction, and I'll tell you a little bit more. I have no relevant financial disclosures. I've done a little bit of work on device development for a device called PatchRx, which is related to medication compliance. So we're going to talk about addiction versus chronic pain and physical dependence. We're going to talk about medical and psychosocial treatment options for comorbid addiction alongside chronic pain, and then talking about strategies for counseling patients regarding addiction and linkage to specialist treatment. I am board certified in anesthesiology, pain medicine, and addiction medicine, which is kind of a unique combination in a clinician that you may not find in a lot of other places. So my role here at the Atlanta VA is I run a super specialized complex pain clinic where I care for patients who have pain, who have refractory mental health issues, oftentimes who have substance use disorders. You can imagine that this is a challenging combination of patients that I see in a very difficult cohort, but on we persevere. And this is actually a lecture that I initially started developing for pain management fellows, whom I teach on a regular basis at Emory and in other places as well. So let's talk briefly about how addiction happens. We know that the limbic system, which you guys are aware is involved in emotion, behavior, memory, and long-term motivation, is implicated in this. And specifically, within the limbic system, we have the mesolimbic or the reward pathway, which is a dopaminergic pathway. And Dr. Early will get into this, I think, a little bit more deeply here in a couple of sessions. But we have the ventral tegmental area connecting to the nucleus accumbens, as well as the prefrontal cortex. And essentially the release of dopamine coming from that NAC, that nucleus accumbens, into these other areas kind of ultimately can affect the way that a lot of our patients look at these substances and look at these drugs of abuse. Essentially, it ultimately affects executive functioning, which we all know is managed or monitored by the prefrontal and frontal cortices. And you can see really nicely, and hopefully this pointer will point. There we go. We have your VTA here releasing our dopamine into this area, the nucleus accumbens here, the amygdala down here, as well as the prefrontal and frontal cortices. Likewise, over here, we have something similar, VTA into these various areas. And that dopamine release that we get coming into these portions of the brain basically change the way that our brain functions relative to these substances. And I'll explain that in a little bit more detail. We know that dopamine is the pleasure neurotransmitter. It's released when we eat, when we sleep, when we drink, when we have sex, when we urinate, when we defecate, when we do life-sustaining activities, right? And unfortunately, the levels of dopamine that's released kind of in that process ends up being a lot less than the amount that we find with various substances of abuse. And this results ultimately in corruption of our reward pathway. Specifically, when you take a look at these numbers, we have this is rat studies, and these are rats looking at food that happens to be around. If you look on the y-axis of the curve, you see percent of basal dopamine output, meaning that the amount of dopamine that's released when the rat is in presence of that food. And you can see after it's done eating, that rat is very happy, has got some nice dopamine release, and is enjoying him or herself. In the second graph there, we have sex. So these are male rats who are looking to see what's going on when a female rat is present. And you can guess around that 200 mark, that second square there, you can anticipate what's probably happening to that very happy male rat right around that time. Moving forward, what we see, sadly, is that with substances of abuse, and these are, by the way, prescription amphetamines that you're looking at in the upper left-hand corner, we see release of dopamine of 1,000 to 1,100% higher than the normal. Cocaine, 300 to 400%. Nicotine, 200 to 250%. And that yellow thing you see on the lower right is a continuous morphine infusion at 10 milligrams per kilo. Imagine what that would look like with heroin, fentanyl, nitazines, all these other different things. Imagine exactly how much dopamine is being released in the patient's brain, exactly how, after repeated use, this is going to result in corruption of our reward pathways and ultimately change our patients' motivations from trying to do normal everyday things, support their families, go to work, whatever, to become sort of like this. And so the reality is that addiction happens in some people, but not ultimately in others, right? So we know that genetic factors are responsible for about half of our vulnerability to addiction, right? Which is a big deal. So if that means you have a first-degree relative, right, who has, some sort of substance use disorder. I personally have an uncle who has one. I have to be on guard for my entire life, and I have to be very cautious with my kids too, and make sure that they understand that there's possibilities that they have predilections to this as well. Environmental associations, are obviously very, very important. Things that we more classically associated with substance use disorders, low socioeconomic status, within group peer deviance, history of abuse, of course, drug exposure, where we, of course, play some extent in our specialty, and of course, mental illness, we would be remiss not to mention that as well. So the criteria for a substance use disorder is basically 11 criteria divided into 4 major categories, although 4 categories are not actually official. Impaired control, social problems, risky use, and pharmacologic effects. So impaired control means that you're having cravings for something or inability to cut down. A social problem would be you're messing up at work, you're screwing up at school, you're not showing up to places where you're supposed to be. Risky use would be, one example would be continuing to drink alcohol in the context of ongoing liver cirrhosis, or utilizing, various uncleaned or contaminated syringes or other equipment to inject. And last is pharmacologic effects, which is primarily tolerance and withdrawal. So of those 11, 2 to 3 is a mild substance use disorder, 4 to 5 is a moderate substance use disorder, and severe is greater than or equal to 6. And you can see we have alcohol use disorder, cocaine use disorder, opioid use disorder, methamphetamine use disorder, et cetera, et cetera, et cetera. So all the substances basically fit within this in the DSM-5 criteria. So these are the criteria for opioid use disorder, and I've had veterans, my patients, tell me these very things. Number 2, I've tried to stop using a few times before, but I just start using again. Number 4, I wanted to use so badly, I honestly couldn't really think about anything else. Number 6, I can't stop using it, even causing problems with my friends, my family, my boss, my landlord, etc. And so what I want to really drive home, and what I think the speakers after me will also drive home, is that addiction is a neurobiological disease, right? It's not a character flaw, it's not a moral failing, it's not you're not strong enough or I'm not strong enough or whatever. This is a problem that begins in the brain. And even though it requires treatments that are necessarily not related to the brain per se, that are related to behavioral elements, the reality is that we can't stigmatize these patients. We can't judge these patients. We have to treat them just like we treat anybody else who has a chronic disease, because that's what addiction is. It's a chronic, relapsing, remitting disease. And we don't treat hypertension and diabetes by saying go to detox for a week or, just be stronger for the next couple of months and you'll be fine. No, we treat that with medications, we treat it with therapy, we treat it with exercise, we treat it with a lot of things. And we have to do the same thing with substance use disorders. So there are some behaviors, and man, the formatting on these slides is not exactly what I wanted, but it is what it is. So behaviors POUD stands for prescription opioid use disorder. So these are behaviors that are more suggestive, right? This is from a very old article in 2012, prior to the actual DSM-5 criteria coming out. But you can see the ones that are on here: deterioration in work, illegal activities, multiple episodes of lost prescriptions, resistance to change therapy, stuff like that, is clearly going to be more suggestive of not just prescription opioid use disorder, but obviously just any general category of OUD. Less suggestive are patients who have more kind of pain issues, medication hoarding, requesting specific pain medications, openly acquiring similar medicines from other providers, different things like that. And so it's important to distinguish between these as you're actually treating these patients to figure out what it is they actually need. Do they need treatment for pain? Do they need treatment for their substance use disorder? Or perhaps very commonly, do they actually need treatment for both, right? And that's one of the things that I do. I don't necessarily expect everybody in this room to go and start doing that. But the reality is that getting these people to the right places will substantially improve their quality of life from a pain standpoint, and also probably protect them potentially from relapsing and maybe even dying. So how do you treat addiction? In general, we have our non-pharmacologic therapies, and I'm not going to go into all of these in excruciating detail because it's kind of out of the scope of this talk, but the point is that there are many different adjunct behavioral treatments that we use to treat substance use disorders. And it's important, my colleagues will probably talk in more detail about them, but it's just important to kind of be aware that all these things exist, and it's not just literally telling a person, no, be stronger and be better. There's literally things that we can do that are evidence-based. In addition to that, in addition to non-pharmacologic treatments, we of course have pharmacologic treatments. And it may surprise you to actually know that the only 3 substance use disorders for which there is any kind of medication-assisted, medication treatment that's FDA approved: alcohol, opioids, and tobacco. So if any of you have patients who have cocaine use disorders or methamphetamine use disorders or other stimulants or whatever the situation, cannabinoids, right? There's nothing for that either, right? These are the things that we have. And so it's important to recognize, by the way, that naltrexone is used for both opioid and alcohol use disorder because of its mechanism as a mu-opioid receptor antagonist. And I'm confident my colleagues will get into that more deeply moving forward. There's also an interesting phenomenon called complex persistent opioid dependence, which is actually first described by Jane Ballantyne when she was up at Harvard, and Ajay Manhapra, who is an internist actually working within the VA system. So CPOD, or as we call it, is basically a condition where there was initially a therapeutic context of pain treatment, meaning that there was a prescriber and there was a patient, and opioids were started in that context. The problem is that after a while, a patient becomes very, very difficult to taper. They start to have aberrant, medical and psychosocial issues. They start to have difficulty tolerating an opioid taper. Mainly, their function just goes to crap, and they can't really do much. So it's probably a combination of a psychological illness as well as a medical illness, but it kind of is sort of the in-between between the physiological opioid dependence that patients would have just on being on opioids for years versus actual true opioid use disorder, right? The CPOD diagnosis is kind of somewhere in the middle. And there is some evidence, limited evidence, that patients may benefit with buprenorphine in this regard, with this condition. So, by the way, people ask me all the time, whether it's my pain fellows or people, different folks at national conferences, they say, well, Dr. Potru, you treat chronic pain and you deal with these patients who have substance use disorders. Should we just be putting everybody on buprenorphine for chronic pain? And my answer to that is absolutely not. Just like every single patient who has chronic pain, not every single one of them should be on an opioid, right? Just like that, not every single one should be on buprenorphine either. We know it's safer. We know it's better in certain ways, less side effects, less likely the ceiling effect on respiratory depression, all those wonderful things that we know about it. But the reality is that it's still not for everyone. Just like no treatment is for everyone. If you had 5 people coming in for hypertension into your office, would you be giving them exactly the same pills for their hypertension? Of course not. You would be doing individualized treatment and individualized care. And it should be the same with chronic pain. A lot of the things that we tend to miss, especially things we tended to miss about 20 to 25 years ago, is that we should treat pain with just 1 or 2 tools, right? And in that context, let's just say we created some challenges that we're facing now here in America. So it's important just to keep that in mind, that pain care needs to be individualized, and that buprenorphine, as much as people would like to believe it, is not a silver bullet by any means. So the one thing that's important to talk about when you are talking about patients who have chronic pain and figuring out how best to treat them is the opioid risk tool. And I'm not going to go through every single one of these criteria and exactly how to ask these questions and whatnot, because you guys can do all of that. But this is something that's useful. It's an evidence-based, validated tool that we use in the pain clinic to make sure that if we are prescribing opioids to somebody, that we're hopefully not going to create more challenges for them. So the pain pathway, this is really important to remember. And what I specifically want to point out is 2 things. Well, one thing, really. You have the amygdala here, and you see if somebody cuts themselves on the hand, you see those signals kind of coming through here, and you see up this green line up here into the amygdala. And I'll show you over here as well. Let's see, you cut yourself on the hand over here, you got some synapses here, you got something coming up here into the amygdala. Well, guess what? Didn't I just talk about the amygdala being involved in emotion, behavior, long-term motivation, all that kind of stuff? The reality is that pain and emotion and substance use disorders, all to some extent, are housed and processed in the amygdala. And you can see how symptoms of post-traumatic stress, symptoms of anxiety, symptoms of depression might get mixed up with pain symptoms too, right? And that's why sometimes I like to tell patients, especially my vets who have pain and PTSD, I say, look, your pain is like one fire and your PTSD is like another fire. And so when your post-traumatic stress kind of gears up and gets going, gets crazy, it's pouring gasoline on the pain fire. And then likewise, when you start to hurt more, your pain is pouring gasoline on the PTSD fire. And the reality is that the patient's not going to get better until we actually take care of both things. So, and I specifically want to point out here, this is the most important thing that you're going to see on this slide, is that 50%, it's actually 51% if you want to be accurate, of the opioids in the United States as of 2017 went to patients with mood disorders. So that means depression, anxiety, PTSD, stuff like that. Which kind of begs the question, are we treating physical pain or are we treating emotional suffering with opioids? Or are we actually really truly treating both, right? What are we actually really doing? And you could have the best pain psychologist or the best therapist in the world. Half of them still aren't going to be able to figure out exactly what it is we're doing for these folks, right? So it's just important to remember that the various types of traumas that we experience in our lives can manifest as centralized pain syndromes, your IBSs, your fibromyalgias, your chronic migraines, your pelvic pains, like all these other different types of things that we see that we often can't find an organic cause for, end up as centralized pain syndromes, resulting as manifestations of physical, psychological, childhood, emotional traumas, different things like this. We think that there may be the amygdala, of course, can be involved here. We think there may be some glial cell activation that's involved as well. So when you're looking, this is the most important part of this talk, obviously. When you're looking at the patient who has a substance use disorder as well as chronic pain, how are you looking at that patient clinically, and what is it you're actually going to do for them? The reality is that this all begins. Your entire approach and your entire assessment starts with, do I want to take care of this patient, right? Because a lot of times these patients will end up discharged, right? And will end up sent away for one reason or another, whether that's an inappropriate or disconcordant urine drug screen, whether that's, maybe not having the best behavior relationship with the medical practitioner who's trying to care for them, whatever that situation is. So the thing is that this patient, as non-compliant and challenging as they may be, they're still better off under your care as a clinician than they are out there without a clinician. Because we all know one pill kills, right? We all know fentanyl is hiding out there in all the pills that they might be interested in obtaining or purchasing. So as hard as it may be to care for some of these people, I would encourage you and advise you, please do the best you can to do so, right? Because if you can't and if you won't, that means that unless somebody else is doing it, they're going to be out there on an island. And when they're out there on an island is when really bad things happen. So, as I said, addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. And we don't need to read that entire second paragraph, but what's important is that it has impairment in behavioral control. That's the most important thing, is they lose control over time in a pathologic way, as we've already discussed. So when you talk to a patient who has a substance use disorder, a lot of times if they have long-term sobriety, they will tell you, I don't want medications. Please don't give me anything. Whatever they tell me, they're like, whatever injections you can do, whatever therapy you've got, whatever other things you can do without giving me something that's going to mess with my brain, please give that thing to me. Right? And a lot of them will say this. They'll ask if things are habit forming. I literally just had somebody refuse gabapentin the other day because he had heard somewhere on the news that somebody was abusing gabapentin. He's like, I don't want that. Like, I'm good, please. And they will often ask if treatments are likely to affect their mood. This is what I hear a lot from my patients who have SUDs. If they have an undiagnosed substance use disorder, they're not going to do any of that, and they're going to ask you repeatedly to get various psychoactive medications, whether those are opioids or benzos, stimulants, whatever that kind of looks like. And of course, if they have short-term sobriety, who knows? It could be anywhere in between. And brain changes can take a long time to actually manifest in patients with SUDs. There's some really cool studies that Nora Volkow, who's now the head of NIDA, did a few years ago, where she took a look at patients who had used cocaine many years before. And what she did is she had them sit in a movie theater, and she showed them a bunch of pictures of like cake and pizza and foods and horses and all kinds of random things. And she, just for a very split second, put a tiny bit of cocaine paraphernalia on one of those pictures. It was literally, probably shouldn't even have been noticeable by some of these folks who had used cocaine in the past. But I'll tell you, when they did fMRIs afterwards, their nucleus accumbens lit up like Christmas trees, because they still had, 15, 20, 25 years later, still had that kind of crazy rewired brain circuitry related to their cocaine use prior, which is a little nuts if you think about it. So one of the things that I do, and I'm not telling everybody to do this, one of the things that I do, I disguise my addiction evaluation as a pain evaluation. I'll start asking patients how long ago they started using their pain medications, how they use them, what time of day they use them, if they find themselves running out, do they find themselves experiencing withdrawal symptoms? And basically, when you start asking the patient about their pain first, and then you kind of come into the addiction or SUD questions later on, eventually you'll start to realize that the patient doesn't even know that you're asking about addiction, right? Which is actually really cool. By the way, a lot of patients, including one I saw in our addiction clinic at the VA, would complain to me about compulsions to be out of pain. That's what he said. What he didn't realize was that he was being prescribed OxyContin 4 times a day and was using it about 10 times a day, and just said, I just need more OxyContin, right? This has nothing to do with addiction. This is a pain problem. Sadly, unable to realize what was truly going on. By the way, don't ever say the word pseudo-addiction to me, because that is a term that was created by Purdue Pharma and a guy who worked for Purdue Pharma. So if I ever meet that person, I will have some not so nice things to say to him. But that's not a concept that you should ever have considered to be real, because it's not. So the way that I've been able to generate, so like I said, I have my uncle who has a substance use disorder, but some days when I'm in the clinic and it's hard for me to relate to a patient who has SUD, I say, well, what's the best way for me to relate to this individual human who's sitting in front of me? What's the best way for me to show empathy? What's the best way for me to sit down and care about their story? And what I do is I imagine my uncle sitting there in front of me, right? In the clinic or, when I'm in the operating room in the OR, right? To say, how would I want this person to be treated? How would I want my family member to be managed by the healthcare system? Would I want them to be stigmatized? Would I want them to be judged? Would I want them to be ignored? Would I want them to be marginalized? And of course I wouldn't, and neither would any of the people sitting in here. Everyone in here, I guarantee it, has a friend, a family member, a spouse, a partner, a child, somebody who's been affected by a substance use disorder. And if you imagine that person sitting in front of you in your clinic, trying to figure out how to best manage them, how to best care for them, how to best operate on whatever the situation is, right? This will actually cause you to generate some real empathy, and that will show through on your face, which is the most important thing. Because once a patient realizes that you don't care or that you don't believe them, it shows. As good as we are as clinicians at hiding our opinions sometimes, when we really don't care for somebody or really not interested in treating somebody, it shows through on our faces. And so this is the way that I found, for me, has allowed me to generate empathy for people and really kind of get them to trust me, build rapport with me, so that I can actually treat them in a way that will be helpful to them and also safe for them, which is probably even more important in this context. So it's important to keep in mind to frame everything in the context of safety. I don't want anything bad to happen to you, whether that's from a pain standpoint. If that's me and I'm choosing an injection for them, I say, I don't want to do this because the risks outweigh the benefits, and I don't want you to develop an epidural hematoma, so we're just not going to do this today, right? Versus if you want me to prescribe this thing for you that I don't really think is safe in the context of everything else that's going on, whether it's your medical history or substance use, whatever that is, I don't want anything bad to happen to you. Your safety is my first priority. Remember, primum non nocere, all those things that we learned back in medical school. Remember that chronic pain patients, especially even with or without SUDs, will have pain flares and exacerbations. And they actually look more like opioid-tolerant patients rather than opioid-naive ones. So a lot of times my colleagues in anesthesia will ask me, they'll say, hey, Sudheer, I had this patient the other day with an alcohol use disorder, and we didn't really want to give him opioids, so we just gave him a little bit. If the normal is we give 1 milligram every 6 hours, we give this guy 0.5 milligrams every 8 hours, and he was screaming in pain. And I said, well, you guys, he's tolerant, right? That your strategy was just flawed from the get-go here, right? He needed more, actually, not less. And the sad thing is, of course, is that uncontrolled pain is a risk factor for relapse. How many patients have we seen who are drinking alcohol to control their pain or using other substances to help deal with their pain or trauma or whatever that is? So we have to be really careful and think about that patient journey as they come to us to figure out how to best and most appropriately treat them. So, with an unexpected test result, like your urine drug screens or other different things, your pill counts, whatever, it's time to ask more questions. If you're unsatisfied with the answer, or if it's inconsistent with objective findings, it's time to ask more questions. Or if somebody tells you with any medication that you're prescribing, if they say, I take it and then I can finally go to sleep, or I take it and then I can finally relax, or I take it and then I feel way better, you have to start asking some more questions, because there may be something going on that's just unrelated. You can discover a substance use disorder, a complex persistent dependence, or maybe even some other underlying mental health issue that potentially the patient might need treatment for. So treatment considerations, and I'm not going to belabor this too much, but I want you guys to think about a Butrans patch or Belbuca if this person comes to your clinic and you're saying, okay, well, I'm not sure what I want to do with them, but I definitely know I don't want to continue their Percocet or continue their hydrocodone or whatever that might be, their Dilaudid. Even though buprenorphine is still an opioid, right? And I know I talked about it before, that it's not great for everything. But the reality is that sometimes it might be helpful to bridge people if they have to get from your clinic to somewhere else. Or if you really feel that the treatment they're getting is inappropriate, right, and you want to switch them to something different, buprenorphine is a very reasonable choice and something that they should be able to tolerate just fine. And by the way, there are many different formulations of buprenorphine. There's the microgram formulations that we use for pain, and then the milligram formulations that we use primarily for opioid use disorder or cravings and withdrawals. My colleagues will certainly get into all of that, so I won't belabor it, but it's important to keep that in mind. So, and that's why I do say on here, by the way, buprenorphine may be somewhat protective, like Butrans patch may be protective from overdose, but typically the receptor occupancy of it is too low really to actually limit all the cravings and withdrawal symptoms that people usually get with opioids. And then, of course, assume fentanyl is in everything, including, by the way, not just opioids, but cocaine or other stimulants or other different things. Fentanyl is literally hiding inside everything. I started reading The Least of Us by Sam Quinones, who's the author of Dreamland, and literally the fentanyl's been inside everything for a lot longer than we actually think it has. Not even the last 10 years, probably actually the last 20. It's just that it's really become a lot more persistent and more of an issue recently. So, what time is it? Oh, so I have plenty of time. I guess I can talk about receptor availability. So when we look at buprenorphine products, remembering that our butrans patch, which is dosed from 5 mics per hour all the way up to 20 mics per hour, so 20 micrograms per hour times 24 hours is 480 micrograms. Belbuca, which is the buccal formulation, right, what we also use for chronic pain, is dosed anywhere from 75 micrograms Q12 to 900 micrograms Q12, which is 1.8 milligrams, okay? And so when we look at these numbers, what we're actually seeing is that this is the receptor occupancy of buprenorphine, right, of the mu opioid receptor. We all remember that buprenorphine is a partial agonist at the mu opioid receptor, meaning that, and it has very, very tight binding affinity for that mu opioid receptor, which is interesting. So when we think about dosing buprenorphine in the 1 to 2 milligram range, what that's going to do is that's going to help treat pain because it's going to agonize the receptor to some extent, but it's not going to be a high enough dose to prevent cravings and withdrawal symptoms. And so our Belbuca or our Butrans typically are going to wind up in this 1 to 2 milligram range. 1 to 2 milligrams over there. And you see that the receptor occupancy in those is anywhere between 50 to 80%, right? Versus our OUD dosing is typically ranging for most people from 8 to 16 milligrams. And you can see that the receptor occupancy of buprenorphine in those doses is much, much, much higher. And you can see the numbers there are the remaining receptors that are liberated, right? And in the 8 to 12, 16, we're looking at 20 to 30, 13 to 20, 9 to 20. That's the point, is that receptor occupancy is actually a big deal with buprenorphine and kind of change things from that standpoint. So let's say the patient might have some sort of substance use disorder. How do I have the conversation? What are the things that I'm supposed to say to make sure that this is going to be a good conversation? So avoid stigma and judgment. I think this one kind of goes without saying, and hopefully I've driven that point home by now in the last 20 minutes. Make sure you're framing everything in the context of safety. I think we already talked about that. And so again, this really depends on whether or not you want to keep the patient or whether or not you want them to go somewhere else. And by the way, there's no judgment here, honestly, either way. If you feel like the patient really needs treatment from a different provider and you want to send them there, you should, right? If you need help, get help. But the reality is that the patient, at least to some extent, getting help from a medical provider is better with you, with maybe your limited level of knowledge, than nobody, right? And that's important to remember. And so what I say to the patient, when I feel like I need some, even though I'm a certified addictionologist, there are times when I still need help, and there are times when I still need assistance. And I say, I want to help treat your pain, but I also need some help ensuring that what I'm going to do is safe for you. So sometimes that means asking my psychiatry colleagues if it makes sense in the context of 8 billion psych meds, if I should add a duloxetine, if I should add a gabapentin, if I should add a whatever it is, and different things like that. So if you don't want to keep them, then you say, honestly, it's a little dangerous for me to care for you with the tools I have at my disposal. It's time for us to find you some real help. And it doesn't necessarily mean, by the way, that you're discharging the patient. It doesn't mean that you're abandoning the patient. It means that you're getting help, right? And it's important to make that distinction because a lot of patients will ask you, they'll say, well, are you just kicking me out of here? Like, I need help, doc. Like, what, are you not going to do anything for me? And what you say is, what I am doing for you is getting you to the place where you actually really need to go. Right? And if you explain it in that context, sometimes they receive it a little bit better. But of course, everyone is different. And of course, you never have you always have people follow up as needed. Don't discharge people from your clinic, right? It creates all kinds of legal problems, potentially medical challenges. You don't want to mess around with that. Just always say, follow up as needed if you're not giving them the thing that they really want. And one thing I always emphasize to my pain medicine fellows, not prescribing opioids is not the same thing as discharging somebody. Not prescribing lisinopril is not the same thing as discharging somebody. Not prescribing any particular thing or doing any particular treatment is not the same as discharging somebody from your practice or from your facility, right? So there are always lots of different things that we can do for people, whether it's related to pain or not related to pain at all. So honestly, from a conceptual standpoint, I say there are always multiple treatment options. You just have to offer the ones that you think are best for that individual person. So we'll talk a little bit more about buprenorphine for pain, and these are the formulations related to it. You can see that the microgram dosing ones, which are the Belbuca, and then the Butrans at the bottom, are in microgram dosing, and then we have the other ones in milligram dosing. We'll talk a little bit about buprenorphine for pain, because I think it's helpful. So Lynn Webster and several of his colleagues published in 2020 in the Pain Medicine Journal, basically how to convert to buprenorphine from various other opioids. And you can see he divides it from the less than 90 morphine equivalents there on the left side of your screen to the greater than 90 morphine equivalents on the right side of your screen. And I'm happy to go over that in more detail if necessary, but the point is that there are tools out out there if you're interested in taking your patients and converting them from standard, regular, traditional opiate agonists to buprenorphine products. So is buprenorphine effective for chronic pain? And this is the question that people have been asking me for, God, how long at this point? This is a really, really interesting and cool. So in that same paper, Webster actually cites a retrospective cohort study done by McIntyre et al., where they literally, I kid you not, this is a phenomenal study that they did. They took a look at 100 patients who had opioid use disorder, and they said, okay, 50 of them, they did a retrospective study. 50 of them came off their buprenorphine. They were all on buprenorphine for OUD. 50 of them came off of it, and 50 of them stayed on. And they all underwent general surgeries. We're talking choles, we're talking appies, hernias, generally fairly straightforward laparoscopic procedures. And they looked at their post-operative opioid use. And they said, okay, well, who's going to use more? Is it going to be the people who are on buprenorphine, who stayed on it, or the people who actually came off of it? And believe it or not, of course, not surprisingly to me, but maybe surprisingly to others, the people who came off their buprenorphine prior to surgery used, on average, between post-op day 0 and post-op day 1, about 100 milligrams more of IV morphine on their PCAs. Which begs the question, were we treating withdrawal that we had actually induced by taking them off their buprenorphine, right? Or were we actually treating the post-operative pain, or both? Who the heck knows? There are at least 2 or 3 other interesting studies and case reports that really kind of show that buprenorphine is a powerful, powerful analgesic medication. For those of you who don't know, buprenorphine is a derivative of thebaine and actually was created as a drug for pain back in the 1960s. In the 80s and 90s, for those of you who were practicing then, many of you may remember using its IV formulation, which is called Buprenex, to treat acute pain in hospitalized patients. Buprenorphine is a fantastic drug for pain, and it's really, really useful in the appropriate contexts. So there are a couple different studies here that I won't bother to bore you with too many of the details. Long and short of it is that buccal buprenorphine, Belbuca, has actually been shown to be better than placebo for low back pain. Of course, these are industry-sponsored studies back when the Belbuca was first being created and synthesized. So you got to take everything with about a bucket of salt, like you do these days with the pharma companies and everything. But so basically, the point is that it was better than placebo, and in certain instances, for some patients, it serves to be a better option. Similarly, similar kind of study here showing efficacy, tolerability of buccal buprenorphine in this context to treat chronic pain. So there's also a really nice meta-analysis that was done in 2018 by one of my colleagues, Anuj Bhatia up in Toronto, basically he compared directly methadone to buprenorphine from a pain management standpoint in patients who had OUD, and they actually found that there were differences in pain relief between methadone and buprenorphine, but not really, like compared to nothing or compared to placebo, but didn't really find any differences between the 2 drugs themselves, methadone and buprenorphine for pain relief. And there are a few more studies here. The long and short of it is that 14 of the 25 studies reviewed showed clinically significant benefit with buprenorphine in the management of chronic pain, and no adverse effects were reported in any of the studies. So again, it's a useful drug, like I'm saying. There was also a meta-analysis that was done in Hong Kong that was published last year, basically showing a statistically significant and small reduction in pain intensity compared to placebo, specifically related to chronic non-cancer pain. So the most interesting one of these, actually, in certain ways, was a study done by Jonathan Deitch, in Fort Myers, where he took a look at, he was a pain physician, had a bunch of patients who were on very, very high doses of opioids, took all of them, or virtually almost all of them, and switched them all to buprenorphine. And what he actually found was that a number of them did well, but unfortunately, the patients who were on the highest levels of morphine equivalents actually are the ones who did the worst, which kind of begs the question, sort of, what was he really treating? Was he treating with all those opioids 400 to 500 morphine equivalents? Was he treating pain? Was he treating suffering? Was he treating both? And of course, as we said, it's hard to know sometimes. So, take-home points. Addiction is a terrible neurobiological disease and not a moral failing. Please treat these patients compassionately, as you would want your own family members to be treated. Frame every discussion in the context of safety to make sure that you're not going to cause more problems. Remember that uncontrolled pain is a risk factor for relapse. Think about buprenorphine for pain and OUD. And of course, should we be using bup or a full opioid agonist? The jury's still out. And that is what I have. If you're interested, that QR code that's on there is actually a link to my LinkedIn page. I'm in the process of creating a curriculum related to difficult conversations pertaining to opioids and other different things. I post about articles related to difficult conversations and opioids and different stuff all the time. If you're interested, please check it out. Thanks.
Questions? Questions from anyone? Here we go. Dr. Potru, I wanted to talk a little bit, if you can, about cannabis in pain management. My colleagues seem to be successful. I heard that pain is used by 30% with cannabis use legal, illegal. What are your thoughts? Because it's such a headache when it comes to patient care and cannabis discussions. Thank you.
So to be clear, your question is asking me about cannabis and opioid co-use? That's what you're asking about?
Does it have utility in pain management?
Yeah. So I think the evidence to this point does demonstrate to some extent that there is some benefit from cannabis in pain management. Of course, the problem is that cannabis is still such an unregulated industry that it's without things being standardized, it's really hard for me to say like this amount or this puff or this edible or whatever it is appropriate to prescribe along with opioids or gabapentinoids or other different things. Maybe that will change, and I hope that day comes. But at this point, when I'm counseling a patient about cannabis and opioids, I'm usually saying something along the lines of, look, you want to use this stuff for your pain management? Have at it. I'm just not going to give you this thing that could potentially interact with it. Because there are interactions with cannabis and opioids, right? And I think we all know that. So a lot of patients get upset with me when I say that. They say, oh, you're practicing old medicine. Cannabis is not, it's now people are using it for medical reasons. I say, that's fine. But there's a drug-drug interaction between cannabinoids and the opioids that I would theoretically prescribe for you. So because that drug-drug interaction exists, it has nothing to do with you. It has nothing to do with the law. That has nothing to do with what Joe Biden or Kamala Harris or Donald Trump might say about cannabis, right? It only has to do with the drug itself, that there's an interaction between cannabinoids as well as opioids and gabapentinoids and all the other various sedating things that we use in pain management. So I'm very clear about that. Does that make sense? Perfect.
I have two questions.
Yes, sir.
The first question is, in those last studies where you looked at multiple different things showing the efficacy, how are those patients tested beforehand, stratifying according to the degree of problems with their back? Do they have herniated things? Do they have things with their brain? They have all those things. That's question number one. So what's the answer? So
question number one is they weren't. They were literally just low back pain. That's what it was. And when these are studies done by drug companies, right? So they're, let's just say, invested in making sure that their therapy looks good, obviously. And I'm obviously demonstrating that with that caveat. As my understanding, having read them, although it's been a minute since I did, they were not specifically stratifying related to the cause of their back pain or the cause of their pain in general.
Yeah, because I think then if we actually look as thinking physicians, then these are all useless things, because if you don't know where you are, because you've already said it's multifactorial. Mm-hmm. That's number one. Number two is you presented a very good thing concerning substance abuse. This goes along the whole idea of passivity in terms of you do things for people. That's the medical model versus the active model where then people do things in functional medicine and things. And I think we need a marriage. It's like a bird. You need both wings. And I think with this stuff, we need both the left and the right wing to put these two things together. And you've considered doing that because in our practice, we're putting these things together.
Yeah, I mean, I think you're right. That's absolutely true. In pain management, we think, I talk about passive care. And the reason why I talk about passive care during a meeting is because passive care is one of the things that has a lot of evidence for it because it's done by big device and big pharma, right? Not to be a conspiracy theorist, but they're the ones who run American medicine anyway. I would say that, active care, the limited studies that do exist on active care in functional medicine demonstrate a lot of times better outcomes than any of the drugs that we prescribe, any of the injections that I do, a lot of those other different things, to the extent that the evidence is available, right? And I think that combining the relevant aspects of things that we do to people and the things that they do for themselves, or to themselves or for themselves, depending on what your perspective is obviously critical in managing their pain and improving their overall outcomes and their overall, function or quality of life, right? So I fully agree with you. That's something I try to do in my practice, but of course, as an interventional pain specialist, right? The way I was trained was, where do I put the needle to make this better? Which is not a great way to treat pain, as I'm now realizing a decade after I completed my training. But that's just how we think as pain specialists. And I think that now finally things are starting to change. People are looking at lifestyle medicine, functional medicine, all these other different things to really promote that active care option. And that's what I think is really going to be useful for people. So thank you for your comment.
One quick question. Again, excellent presentation. With semaglutide getting all the publicity and stuff, we've noticed that with alcohol and tobacco, and we all believe food is an addiction. Are there ongoing studies with opioids, and do you think I ever get the indication to help with the addiction?
I'm sorry, I didn't really understand your question.
Semaglutide, Ozempic.
Oh.
Yeah, no, in other words,
you're
used
asking
in
about
conjunction.
semaglutide as a treatment for all these substance use disorders. So
apologize.
the answer is yes, to some extent. But I think that the way that it's working, I'm assuming, although we don't actually know, that semaglutide is working on some of these common pathways related to various types of use disorders, whether that's a food use disorder or potentially even a substance as well. I think eventually we will reach a point, because it has shown benefit, at least anecdotal benefit for a number of different things. I think we will eventually be getting into randomized controlled trials regarding that, but I think that's still a little bit down the road at this point. But there's definitely some, as you said, some promise related to it.
I'll throw in a question.
Yeah, here you go.
So you made mention of the opioid risk tool, and I've used that a lot in clinic. I've also used sometimes the Reassort kind of score, particularly for those who I'm worried about respiratory issues from long-term opioid use. I didn't know if you could speak to that and its utility or not in kind of having those conversations of risk-benefit for using long-term opioid therapy or not.
Absolutely. So I like the Reassort as well as the ORT, as well as the CLMM, which is the current opioid misuse measure. While I think the Reassort is very reasonable, I use the ORT only because it's quick. Right, it's fast, and it's something that's actionable, that's easy to use. My understanding is that between all of those tools kind of have a sort of similar validation and similar evidence base as far as their utility and as far as their predictive value. And I wouldn't necessarily fault anybody who chooses one over the other. I think they're all good. I think the ORT is quicker and a little bit, your patients aren't going to be as frustrated trying to fill it out or answer those questions. It's not going to take as much time during clinical appointment, which is the reason why I go to that. But I mean, I think the Reassort is great if you're using it. It gives you more information actually, which is helpful.
We have one more question over here.
Thank you. Hi, my name is Mary. I'm a palliative care fellow. We co-manage quite a bit with our addiction medicine team for patients that have serious illness and chronic pain, as well as substance use disorder. We also talk quite a bit about maintaining sobriety at the end of life and in the setting of serious illness. Sometimes we're able to have conversations, kind of making sure we're empathizing, understanding, validating, all of the things that we would do in any other situation, and making sure that we understand, the importance of this for our patients in this situation. Sometimes what ends up happening, unfortunately, is their pain escalates tremendously, and they're in severe pain, and at that time, they become more open to pain management with opioids, especially when we think about like methadone and buprenorphine. If their prognosis is long enough, that might be something that we recommend for them. And so I don't know if you have what your thoughts would be on those conversations, because it just kind of breaks my heart that sometimes it's what happens that someone has to be in such pain and suffering before we can, advance our conversations and our practice.
So you're asking me how I would approach a patient who is essentially opiophobia, who's scared of opioids or concerned about it? Is that what your question is?
Someone who has a history of, let's say, opioid use disorder, and they're at the end of life or seriously ill, and our recommendation is opioid use.
Right.
But because maintaining sobriety is so important to them in the face of serious illness and at end of life, sometimes they have to suffer a lot.
Right.
And I wish that we had better techniques for communication so that it doesn't get to that point.
So what I would do in that particular instance, these types of conversations I've had before, not necessarily as much with end-of-life patients, but even with patients who aren't. And what I tell them is that, so there are various tools that they've used to attain sobriety, right? Whether those are relapse prevention strategies, whether that's avoiding the people that they used to use with, whether that's the support of their friends and family, whatever. Maybe it's a medication, maybe they've been on a methadone or buprenorphine before. What I tell them is, look, while there are definitely risks to this, right? Every decision that we make in medicine is a risk and benefit analysis, right? And so you have to make a patient, whatever you're trying to convince them to do or whatever you think is appropriate, you have to explain to them what those risks are, what those benefits are, and why one is more important than the other, whether that's the risk or the benefit. That's how you have any medical conversation, right? And so in that context, I would say to the patient, look, we should trial these medicines first. Here's 5 pills. Go home, try it for the next 3, 4, whatever X number of days, whatever your interest is, and tell me how you feel after that. If you really truly feel that, you're starting to feel urges and cravings and different things after, even though you've been sober for 20 plus, 25 plus years, if you really still are starting to feel those things and you don't want to do this, then don't. That's totally okay, right? Even if you say to the patient, look, I'm going to see you every week or every 2 weeks for the next 3 months or 6 months or whatever that is. More frequent appointments are really helpful in that context, right? Because then the patient can tell you, and you can start to see what's going on. You can start to see what their medication use looks like. If they take 3 pills in the first 2 weeks and then now you're 2 months down the line and they've taken 20, right? Things look different. They might be more accepting of the treatment. They might start to be having some of those cravings and different things. And then you can step in at that point and do whatever needs to be done. But specifically in that situation, I would explain to the patient clearly, I would be like, look, we don't want you to suffer. And the reality is that we're not sure exactly how much longer you're going to be around, but at the same time, if the idea is that you're going to be around for some period of time that's longer than a couple of months, we need to make sure that you're able to have some measure of quality of life. So I think that's how I would approach it. Does that make sense?
It does, thank you.
Other questions, comments? If you guys think I'm a total idiot, that's cool too.
Good? All right, thank you. Introduce the next person.
If you found this content valuable to you, please consider joining SMA by visiting sma.org/membership or making a tax-deductible donation. Visit sma.org/give to support our mission. Thank you.